name is Előd-János Zsigmond and my PhD topic is the management of cardiac electronic implantable devices. My vision is that we can create a brighter future if we connect our different scientific fields, and my mission in this great task is to learn from other specialists from you. So far, I have these two ongoing projects which I will present in details. The first one being, in this we are investigating the effect of different optimization techniques in patients with cardiac resynchronization therapy in the context of a systematic review and network meta-analysis. We know that cardiac resynchronization therapy, or shortly CRT, improves symptoms and also mortality in patients with heart failure and long QRS duration. However, up to 40% of patients who receive CRT are non-responders to the therapy, and they, unfortunately, have poor long-term outcomes. We also have some studies which proved that device optimization, meaning optimizing some device parameters, mainly the atrioventricular and ventriculoventricular intervals, may improve response rate, but the problem is that we have many different techniques to optimize our devices and we don't know for sure which one to use. So in our study, we wanted to find the best optimization method to improve response rate and long-term outcomes in patients with cardiac resynchronization therapy. We compared the newest optimization technique, dynamic optimization, with 3 other treatments, namely echocardiography, which is considered the gold standard of optimization, static device-based algorithms, and also fixed empirically programmed device settings, which means basically no optimization, one value will fit all the patients. And we also compared the other 3 treatments to each other. We conducted our systematic search in 3 databases, which yielded us to a total of 28 eligible articles which reported the outcomes we wanted to analyze. The first outcome being echocardiographic response, which basically means cardiac reverse remodeling, increase in ejection fraction, and a decrease in end-systolic volume. In case of this outcome, we included 4 studies with 3 treatment arms, the color of the circles representing the overall risk of bias of the studies. On the forest plot, in this case, you can't see the individual studies, you can see the comparison arms. We found that the odds of response are 2 times higher in case of dynamic optimization, and this also reaches statistical significance if we compare it to echocardiography, which is really important because we know that patients with reverse remodeling have better long-term outcomes. We were also curious about the exact amount of change with dynamic optimization, so we analyzed ejection fraction and end-systolic volume separately. On the middle, you can see the Surka plots, the red line representing dynamic optimization, which performed better than the other treatments. On the forest plot, you can also spot a tendency, a numerical trend favoring the dynamic arm in every comparison. The additional improve with dynamic optimization is relatively small. I don't know if you can see it. It's around 3% increase in ejection fraction and around 11-14 milliliters decrease in end-systolic volume. But this change can be clinically relevant in case of patients who have a suboptimal initial response with other treatments, which can explain the difference which we observed in the echo response rates. Our next outcomes refer to clinical performance. Packer's clinical composite score includes mortality, heart failure hospitalization, and clinical improvement based on New York Heart Association classification and patient global assessment. This outcome was only available for studies which compared the dynamic optimization to echocardiography. We included a propensity match study and 3 RCTs in the analysis, and we found that the odds of response are 1.23 times higher in the dynamic group, reaching also statistical significance with a good overall consistency over the studies. If we are talking about mortality and heart failure hospitalization, this amount can be really appealing. However, we also wanted to know which parts of the composite endpoint improved the most. So we analyzed all-cause mortality, hospitalization, and clinical improvement separately. This way, we were able to include all the 4 treatment arms with a really high number of patients in case of dynamic versus echo comparison. After we analyzed all-cause mortality, we found no relevant difference between the treatments. However, in case of cardiac hospitalization, we found a significantly lower event rate in case of dynamic optimization compared to echo, with an odds ratio of 0.73. Clinical improvement also strongly favored the dynamic arm without statistical significance, but with a clinically relevant odds ratio of 1.37. Based on these results, we can say, or we can assume at least, that the beneficial effect which we observed in Becker's clinical composite score are mainly due to the lower cardiac hospitalization rate and better clinical improvement in case of dynamic optimization. So what can we say in conclusion? We can suggest for clinicians to use dynamic optimization techniques, dynamic algorithms, instead of echocardiography at the time of the implantation to achieve better echo response rate, better clinical improvement, and also lower hospitalization rate. And we have also good news for researchers, because in case of other treatments, fixed device-based settings and static algorithms, we need more trials to draw definite conclusions. Now we are finalizing our cinema assessment, and we also started to write the manuscript. And let's proceed to our second project, in which we are investigating the role of biomarkers in predicting cardiac implantable electronic device infection in the context of a registry analysis. Fortunately, the incidence of device infection is relatively low, but as you can see, it has a high mortality rate. The gold standard therapy is device extraction combined with antibiotics, but this poses a serious risk for the patient and also a serious cost for the healthcare systems. So it would be rational to prevent this complication rather than treat it. But here comes the question, how can we prevent device infection? In the guideline, we find clear recommendation in case of patients who are presenting with fever to delay the implantation until the patient becomes febrile. But we don't really find anything about patients who are presenting with subclinical infection. In those cases, biomarkers, inflammatory parameters, and also hematological parameters could be of use to identify patients who are at high risk for infection. But a recent meta-analysis stated that few studies investigated the correlation between device infection and these parameters. Therefore, in our registry, we want to investigate if indeed pre-implant biomarkers can predict early and one-year device-related infection and also mortality in patients who are undergoing device implantation. On this slide, I listed the main variables which we want to include in our analysis, the most important ones being risk factors for infection, which can be grouped in three main categories, which are patient, procedure, and device-related. And here I listed also the main laboratory parameters which we want to investigate. In summary, the next steps for our projects are manuscript writing for the first project, and we also want to start patient enrollment in the registry as soon as possible. And let me close my presentation with this short quote from Master Yoda, "Do or not do, there is no time for hesitation." Thank you very much.
Congratulations, Előd. This is a very great work. My question would be that are the articles reporting that when the optimization happened after the implantation, and if yes, were there any subgroup where they optimized not initially after the first regular checkup, but after they found that these patients were non-responders, and they are trying to optimize it after that?
Thank you very much. This is a really good question. I think it worth two cards. So in case of these articles, the optimization was done in 1 week after implantation, so either next day or in the first week after the implantation. But I didn't present because we don't have the final data about those papers which optimized patients who were considered non-responders based on some criteria. And also in those cases, so our conclusion was that we should abandon echocardiography in case at the time of the implantation. But we think that we shouldn't abandon echocardiography at all, because in case of patients who are non-responders, with dynamic optimization or with other treatments, we should look into the echocardiography, what does it shows, and if we have to change the values. And the results of the few studies which investigated non-responders showed that around half of the patients can be responder after optimization.
Thank you for your presentation. I'm asking about the practice in your hospital regarding the second project. When do you say that I won't implant that device? So what are you looking for when you are before an implantation?
Thank you very much for the question. Well, previously we considered that if we see a CRP above 5, we should delay the implantation if it's not critical, so if it's not a grade 3 AV block or if the patient is stable. But now we see that, and during the COVID era, we saw a lot of elevated CRPs. We had to implant the devices, and until now, we see that it's working. So if the PCT is not elevated with a CRP, then maybe you should implant the device if it has a crucial indication. But in case if you consider that, so the clinical decision is that the patient has an ongoing infection and we don't have fever, you can implant also temporary pacemaker and then delay the implantation when you cure the infection.
Regularly?
Not regularly. In some cases where we see that there is an indication for it, yes. If we have other signs of infection, respiratory, urinary or GI infection, then we measure it, but not a regular basis.
Do we have any objective measures like 6 minutes walk test or lab test or anything which can correlate to the clinical outcome, morbidity, mortality regarding the CRT therapy?
Thank you for your question. Regarding objective measurements in CRT, it is really hard to say that some measurements are objective, because in case of 6-minute walk test, there are also professionals who mentioned that it matters what kind of shoes you have, not what kind of device, if you are measuring 6-minute walk test. But we also measured that outcome, but I couldn't bring all the results now, and it seems that also 6-minute walk test is increased with dynamic optimization compared to echo and also compared to fixed device settings. Around a 50 meters improvement can be seen if you use dynamic optimization.
Thank you.